The blood supply for the GI tract, as we know, is going to arise from the three midline branches of the abdominal aorta. And on this slide we can see the celiac trunk, which comes from the aorta just after it comes through the aortic hiatus, so somewhere between T12 and L1. And then the superior mesenteric artery comes off just below that at about the level of L1. And then the inferior mesenteric artery comes off at about the level of L3, about one vertebral level above the bifurcation of the aorta, which occurs at L4. So let's address these arteries one at a time, and we'll start with the celiac trunk. We know that the celiac trunk is going to be providing the blood supply to the foregut-derived organs. And so that's going to be the esophagus, stomach, and part of the duodenum. So here we see the celiac trunk coming from the aorta, and it very quickly divides into three branches. One branch, the smallest one, is the left gastric artery, which we see going up onto the lesser curvature of the stomach to supply the stomach. But importantly, notice that it gives off an esophageal branch to ascend along the esophagus within the abdomen, because of course, remember that the esophagus is also part of the foregut, so it's going to be getting its blood supply as well from the celiac. So that's one branch. The second branch is the splenic artery, which we see here heading off to the left. It's typically tortuous, as you see it here, and it heads off to the left to get to the spleen. But importantly, notice that along its path to the spleen, it runs right along the upper border of the body and tail of the pancreas, all along the upper border of the body and tail of the pancreas, right up to the hilus of the spleen. And so as it's going, it's giving off blood supply to the body and tail of the pancreas. So importantly, the splenic artery does not just supply the spleen, it also is supplying the pancreas. And it also gives off some branches to the stomach. And we can see the left gastroepiploic artery here going on to the greater curvature of the stomach. The third branch of the celiac trunk heads off to the right, and that's called the common hepatic artery. And the common hepatic artery ends by dividing into two branches. One ascending branch that heads up toward the liver, and that's called the proper hepatic artery, or the hepatic artery itself. And the descending branch, which is the gastroduodenal. So the ascending branch, or the proper hepatic artery, gives off branches to the liver, right and left hepatic arteries. And then from the right hepatic artery, typically, but not always, we have the branch to the gallbladder, called the cystic artery, which of course is surgically important for cholecystectomy surgery. The descending branch of the gastroduodenal passes right behind the first part of the duodenum and is right up against the back wall of the first part of the duodenum. And that's an important relationship because a posterior wall ulcer in this region, as it perforates through the duodenal wall, can perforate into the gastroduodenal artery, resulting in bleeding into the lumen of the gut tube. That gastroduodenal, as its name implies, gives off a branch to the stomach and another branch that'll take care of the duodenum. So going to the stomach, we have the right gastroepiploic, which ends up anastomosing with the left gastroepiploic from the splenic, along the greater curvature of the stomach. And the other branch is going to take care of the duodenum, but the name of that other branch is pancreaticoduodenal, superior pancreaticoduodenal, and we can see that right here. And that name tells you something important, and that is that it actually goes into the head of the pancreas, and that is the blood supply for the head and neck of the pancreas. We've already said that the splenic provides blood supply to the body and tail of the pancreas. We have the gastroduodenal by way of its pancreaticoduodenal branch supplying the head and neck of the pancreas. And then the branches that have to supply the duodenum traverse the head of the pancreas to get from the superior pancreaticoduodenal artery to the surrounding duodenum. So that's an important point, which is that the blood supply to the duodenum traverses the head of the pancreas in order to get to the duodenum. And it's for that reason that when the head of the pancreas must be removed surgically, the duodenum must also be removed, because the removal of the head of the pancreas removes the blood supply to the surrounding duodenum. The other very important point about this artery is the fact that it anastomoses with this artery that we see here, which is actually a branch of the superior mesenteric artery, which is the inferior pancreatico-duodenal. So going into the head of the duodenum from above, we have the superior pancreatico-duodenal, and from below, the inferior pancreatico-duodenal. And they anastomose with one another to provide a very rich blood supply to the head of the pancreas and the surrounding duodenum. But the reason this is so important is that the superior pancreatico-duodenal is ultimately a branch of the celiac trunk, while the inferior pancreatico-duodenal is a branch of the superior mesenteric artery. So this anastomosis within the head of the pancreas is in fact an anastomosis between the celiac trunk and the superior mesenteric artery, which makes it very important because that would mean that a partial occlusion of the celiac trunk can be overcome by collateral flow, having the superior mesenteric artery pick up the blood supply to the foregut organs that the celiac trunk typically supplies. And the other very noteworthy point is that the region of this anastomosis is right in the region of the second part of the duodenum. And as you'll recall, we said it was in the second part of the duodenum that the boundary between foregut and midgut existed, all of this being foregut, all of this being midgut, and it's at the boundary between foregut and midgut that we anticipated we would see overlapping blood supply between the celiac trunk and the superior mesenteric artery, and indeed that's exactly what we find. So that's the celiac artery. The second artery is the superior mesenteric artery, and of course that's going to supply midgut, and the midgut includes much of the duodenum, all of the jejunum and ileum. Now the jejunum and ileum has been removed from this illustration in order to allow us to see all of these arterial branches, but we do see these branches that are heading out to the jejunum and ileum. These are the so-called intestinal arteries, and those are the arteries that will pass into the mesentery of the small intestine to supply the small intestine. Recall that the midgut is not just jejunum and ileum, but it's also the cecum, the appendix, the ascending, and much of the transverse colon, so we should expect to see branches coming from the superior mesenteric artery to supply those organs as well. And in fact, we see coming from the superior mesenteric artery, the ileocolic artery, which is going to supply the distal ileum and the cecum and the beginning of the ascending colon. The right colic artery, which will supply the ascending colon up to about the region of the hepatic flexure. And then the middle colic artery, which will supply the transverse colon. We see that as each of those arteries, middle colic, right colic, and ileocolic arteries approach the colon, we see that they divide into a branch that heads proximally along the gut and a branch that heads distally along the gut. You see that for the middle colic, we see that for the right colic, we see that for the ileocolic. And those branches then anastomose with one another. So the proximal branch of the middle colic anastomoses with the distal branch of the right colic, and so on for the right colic, ileocolic, and going on back to the most distal of the intestinal branches. So those communicating arteries, those anastomosing arteries, create what in essence is one continuous arterial pathway, which is a series of anastomoses between these vessels, and that continuous pathway is called the marginal artery, or the marginal artery of Drummond. So the marginal artery isn't really an artery itself, it is a series of anastomoses between branches of the middle colic, right colic, and ileocolic arteries, and as we'll see in a few moments, it continues on with branches of the inferior mesenteric artery. So because of that excellent anastomosis within the marginal artery, that would mean that if we said, for example, if we were to ligate the right colic artery, the ascending colon would not be affected. It would maintain its blood supply because the middle colic and the ileocolic would easily take over by way of the anastomosing marginal artery, and so on for these other branches. However, notice that the marginal artery is not actually on the wall of the colon. It's a short distance away from the colon, and there's a series of arteries that go from the marginal artery into the wall of the colon. And those arteries, which are called vasa recti, which means straight vessels, the vasa recti are in fact the terminal branches that are supplying the colon. And importantly, those arteries do not anastomose with one another. They are end arteries. So each one of those vasa recti has a segment of colon for which it is responsible for the blood supply. And so an occlusion of a vasa recta could in fact lead to a segment of ischemic bowel, while occlusion of the parent artery, the right colic artery, would not result in ischemic bowel. Okay? So let's move on to the third artery, the inferior mesenteric, which is of course the artery for the hindgut. We know hindgut is descending colon, sigmoid colon, rectum, anal canal. And so from the inferior mesenteric artery, we see a left colic artery to supply the descending colon, a series, usually about 3 to 5 sigmoidal arteries to supply the sigmoid colon, and then the terminal branch of the inferior mesenteric, that is to say what's left of the inferior mesenteric after the last of the sigmoidals has come off. The remaining vessel is now called the superior rectal artery to supply the rectum. And we see the same pattern that we saw before, where these sigmoidal arteries are branching into proximal and distal branches. They anastomose with one another. Similarly, the left colic divides into proximal and distal branches, anastomosing with the sigmoid artery here. However, the anastomosis between the ascending or proximal branch of the left colic and the distal branch of the middle colic is a bit problematic. Now, this is the region of the junction between midgut and hindgut. And that's why we would anticipate that there would be overlapping blood supply between branches of the inferior mesenteric, represented by the left colic, and the superior mesenteric, represented by the middle colic. And although this diagram shows that there are communications between the middle colic and the left colic in the region of the splenic flexure, in fact, those anastomoses, those communications, are not very good functionally. And so the anastomoses in this region, in the region of the junction between midgut and hindgut, are not good, and therefore the opportunity for ischemia of the bowel in this region is much greater than in other regions of the bowel because of the poor anastomosis. So the region of the splenic flexure is the most common site for ischemic bowel of the entire gut tube because of that. On the other hand, the left colic does anastomose well with the sigmoids. So if you were to occlude a left colic artery, the lower descending colon would do fine because of the sigmoids, but the upper descending colon, the region of the splenic flexure, may not do fine because this anastomosis is not very good. So that concludes the arterial supply.